So good morning, everybody. Today I present before you a case of a 55-year-old Asian female who initially presented to an outside hospital with symptoms of substernal chest pain that woke her up in the middle of the night. Her comorbidities included insulin-dependent diabetes and hypertension. At the initial ER visit, it was thought that her symptoms were non-cardiac and she was sent home. However, she presents 5 hours later because of persistent symptoms, and at that time she was noted to have ST segment elevations in leads V2 through V4. So the patient's taken to the cath lab. The ostial LED is fixed with a drug-eluting stent with TIMI-2 flow. The left heart cath is performed that showed an LV-EDP of 33 millimeters of mercury, and the LVOgram consistent with LVEF of about 10%. Due to persistent hypotension while she was still in the cath lab, she is initiated on Levophed and an intra-aortic balloon pump is placed. At the same time, a right heart cath is performed that shows elevated right and left-sided filling pressures as well as low indices, and hence the patient is initiated on milrinone therapy and sent to the CICU at the outlying hospital. The initial echocardiogram that is performed, again consistent with a low EF 20 to 25%, akinesis in the area consistent with the LAD infarct, moderate anterior pericardial effusion, but no tamponade physiology noted on that, and no significant valvular compromise. A few days go by. The patient is consistently decompensated, needing more inotropic as well as vasopressor support. While still on intra-aortic balloon pump, the cardiac indices have continued to remain between 1.8 and 2.2. Repeat right heart cath, again, pretty similar to what it was at the initial presentation. And now we're starting to see evolution of end organ damage as well, or as some of the speakers have alluded before, the cardiometabolic syndrome. Sustained VT, patient needing amiodarone drip, hypoxic respiratory failure, now intubated and on mechanical ventilation, shock liver, ASC and ALT both consistently above 1,000, and then the transfer call is made for the patient to be transferred to our facility. So the first question that came up for our team was, is it ever too late in the patient's disease process for the patient to benefit from such a transfer to a quaternary center? Obviously, the patient was accepted, otherwise the case would end now. And as most patients show up, she did show up at 2:30 in the morning when I was on call. MAPs were still in the low 50s despite on Levophed, milrinone, and the intra-aortic balloon pump. We initiated vasopressin and epinephrine drips were started. Her ECG, when she first showed up to our facility, looked like this, and so the decision was made for the patient to be emergently transferred to the cath lab for a repeat right and left heart catheterization. The repeat right heart cath, these were the tracings, and we'll go over the numbers here in just a second. So the stuff that I wanted to highlight is in red up here. Obviously, the indices are still pretty low. Her PAPI is 1. Her mixed venous was 36%, keeping in mind she's on 4 vasoactive medications, and she's on intra-aortic balloon pump. And the BSA being 1.7, and that will be relevant as we continue to discuss this case. The repeat coronary angiography, these were the findings. Again, TIMI-2 flow, the stent looked pretty patent. The repeat echocardiogram, when she first presented to our facility, here are some of the images of those. And then the repeat TTE that was performed, again, the left ventricular end diastolic dimension was 2.7. Again, this plays a part into what management options are available for this patient moving forward. The labs, when she first presented to our facility, the troponin was still greater than 70, and keeping in mind this is 3 days after her initial presentation to the ER. The lactate was 5.7. The ABG is as represented, and this is on maximal support with FiO2 of 100% and a PEEP of 10. And the AST and ALT were still elevated significantly. The saving grace up here is that the kidneys have not taken a hit. As you can see, the creatinine is still 0.71. Granted, this is a small Asian lady. However, this is not too far from what her baseline was. So the next question becomes, what comes next? I mean, the Hippocratic Oath still says, first do no harm. So would it be fair to transition this patient to palliative measures? Should we proceed with mechanical circulatory support? If so, should it be Impella or should it be VA ECMO? Or should we go directly to a durable LVAD, keeping in mind that this is a patient that has been intubated ever since he arrived to our facility, and we have not had a chance to talk to this patient directly. So the patient was indeed initiated on VA ECMO. The VA ECMO was continued for about 5 days, but the patient was unable to be weaned off that. This is all happening in the background with a lot of discussions happening with the palliative care team and the family, and kind of assessing what other options may be available if you are not able to wean the patient off. So how long should the patient be continued on the VA ECMO before proceeding with a durable LVAD? What is the role of LV unloading in patients on VA ECMO, preemptive versus bailout? Keeping in mind, in this patient's case, she already had the intra-aortic balloon pump, which was still left in place. Is there a role for LV overloading to promote adverse remodeling? These are all the questions that are coming up on daily rounds and as the team is discussing the case. So the patient was bridged to an LVAD. She received an HVAD as a bridge to transplant. Prolonged hospital course, as would be expected, complicated by recurrent ventricular tachycardia, as well as repeat suction events. These were managed with multiple medications, including intermittent sedative therapy, and permissive hypertension and lower pump speeds were also implemented to reduce the suction events and the VT rate. The patient was discharged home in stable condition and is currently doing well, enlisted for heart transplantation. These are my acknowledgements, my mentors who have allowed me to continue answering my academic curiosities and who are greatly responsible for bringing me to this stage. And once and for all, thank you all for your attention and obviously for this opportunity to present at this. And here's the last clip that I wanted to play. This is the post-LVAD echo that we had prior to discharge on this patient. Thank you very much.